It's a real pleasure for me to be able to give you a presentation on the update from the new World Health Organization classification of head and neck tumors towards extinction of not otherwise specified. I do have some disclosures. As you can see, I receive book royalties, and of course, I'm a standing member of the editorial board for the World Health Organization. If you don't know the name of something, the knowledge of them is lost too. And this is a quote from Carl Linnaeus when he started his original biological classification system. And more importantly, if you give the correct names to cancers, you're going to be ready in the mission to be able to defeat them. And so with that in mind, since 1956, the WHO has been responsible for the classification of tumors in all organ systems with a definitive evidence-based system. And of course, it underpins individual patient treatment as well as what goes on with them for prevention therapy, education and research. And of course, the books are not for pathologists only, they are for everyone in medicine. So what is different about the 5th edition? Well, I think the most important thing is governance, and that is there has been a significant improvement in the editorial board, how the members are chosen and what they do, informed bibliometrics to select authors with more than 3,500 authors involved in the entire 5th edition, lots of links to other organizations from coding and staging to genetics and implementation. Of course, quality and standards have also been improved with a single hierarchical classification managed in a database with an attempt to improve the overall harmonization across the entire series. So this means that the neuroendocrine neoplasms are going to have the same terminology throughout, hematolymphoid lesions, soft tissue, melanocytic, etc., all being managed collectively so that each one has the same terms. There's also been an improvement in the image quality, linked references, standardized statistics using global epidemiology, and of course the idea that SI units are being used specifically as it relates to mitotic figures per 2 square millimeters. Also, in attempt to include multidisciplinary approach to allow everyone to be able to participate in how the classification is created. And then finally, it's going to be done every 5 years. So gone are the days where you may have had 10, 12, 15 years between editions. And of course, with a website hosting all of this with easier access to references and digitized whole slide images, allowing you to make notes as well. So overall, a greatly improved 5th edition complete. So the links out to other organizations in this example include the International Cancer Reporting Group. And in this case, here's just an example of one of the reporting guides for major salivary glands that the ICCR has produced and allows for standardization of what is included in the average report. So ultimately, what is the goal? To improve patient care and, of course, cancer prevention, producing a definitive and evidence-based classification that can be used worldwide. If you go back to 2003, you will see that here is the 3rd edition with all of the members involved in the editorial board and writing groups at that time. Here we were in 2016, just before the 2017 edition inside, because of course it was January. And of course now with COVID and Zooming, we did the same thing where all of us had to meet via Zoom meetings in order to come up with the classification. There were 19 expert editorial board members for this particular review, rather than just the 5 that were included in the 4th edition. And you'll notice there's several asterisks next to people's names, and this is because they are standing members of the editorial board that have expertise in another area as well, and may have been able to implement additional findings here. 251 unique entities are included in the book, 280 authors, give or take a few, with 30 countries represented. And of course, the hierarchical classification means that you're going to go from the hamartoma or reactive tumor-like lesions to benign tumors to uncertain or borderline tumors, and then finally to malignant lesions, with an attempt to be able to classify them from low to higher grade as you go through the overall groups. So, of course, the major changes affecting all of the anatomic sites is trying to reduce redundancy or repetition. And so salivary gland tumors are only presented once rather than being repeated in each anatomic site, even though they may occur in those locations. Soft tissue tumors, hematolymphoid proliferations and neoplasms, and melanocytic lesions are all each given their own chapter, but again, are covering the multiple different anatomic sites that would be affected. The same thing with metastases and germ cell tumors. Bone tumors were grouped into the odontogenic and maxillofacial area, and then a major overhaul of the neuroendocrine tumors, as well as the presentation of genetic tumor syndromes, specifically as they may have head and neck manifestations. I'm going to talk about the neuroendocrine lesions a little bit later on, because I think that is one of the major overhauls for this particular book. So what are the best features for EVER or BFF? Well, they're going to be hosted online, which means they're going to be interactive, mobile device, available anywhere, anytime, and on demand, with multiple more images available in the online version than what is available in the printed text. This also means that virtual whole slides are present for each of the major diagnoses. References are linked out to PubMed with a very abbreviated essential and desirable diagnostic criteria for each group. And of course, radiologists and cytopathologists were included as editorial board members for this time. So if you think about where we are with the new classification, you can tell that those were the 6 original books. And of course, now the head and neck book is out as well. This is not the final cover, but I can tell you there is some arguing and going back and forth about what the images will be on that final cover. So if you go to the WHO classification of tumors online, this is the URL that you can go to, and you'll see that here is an example of the head and neck. Well, let me just show you a little bit about the head and neck tumor site. If you go to the domain, you can obviously see that all of the various anatomic distributions so far concluded are already there, with a little bit of beta included, because this is still in beta version. All of the various anatomic sites for each of the areas are listed here, and you can see that it goes all the way down through the more generalized topics and ending with the genetic tumor syndromes. Well, let me just show you an example of a salivary gland lesion here. You can see distributed by the non-neoplastic, benign neoplasms, and malignant, again, increasing in degree of malignancy. Let's look at sclerosing polycystic adenoma. So first, you can see that there is a left-hand bar where you can actually click on one of those links, and it'll take you automatically to that area within the chapter if you wanted to do it more quickly. However, let's just talk about the fact that, first of all, you can write notes in this, so you can actually add it to a favorite. And here you can see standard definitions, ICD coding, related terminology, localization, clinical features and epidemiology about sex and age at presentation, whether there's an etiology section with pathogenesis, and then, of course, the macroscopic and histologic features, including areas of immunohistochemistry, cytology, if it is germane, as well as the essential and desirable diagnostic criteria, with staging and prognostic and predictive factors at the end. So you'll notice all of these squiggly brackets. Each of these are references. If you click on one, it will automatically launch you to PubMed, where you're able to see the source material. You can actually just read the abstract if you want to do it on PubMed. However, with many of them, you can actually link through to the article directly, as I'm illustrating here, download it, and go and open the article, and now have that particular article ready and easily available for you to read and understand a little bit more about the diagnosis. So when you think about the illustrations, you will notice that they're all along the side here, and there obviously are a number of them for each entity, depending upon the complexity. So if you click on one of these, it'll open up a smaller version of it with a figure legend. If you look at the original, you'll actually be able to see a full, at least 1,000 pixel image. Now, for me, one of the most fantastic things for this book is the fact that we have been able to organize a whole slide image for each of the cases. And if you go to view the whole slide image, you will see one here that you can then drive. So specifically, I'll take it into full screen. You can tell that here you're able to drive this case yourself. You can look at the surrounding tissue, where it is in context, and then actually go all the way up to a super 40x magnification to be able to allow you to see all of the histologic features to be able to make that diagnosis yourself. So in my view, this is a tremendous asset and will allow us to continue to use these books in an aggregated fashion online. So let's talk a little bit about where we are with the overall classification. So sinonasal tract, you can see with each of the last 3 editions, successively fewer entities. And I know this comes as a surprise, but because of the harmonization and reduction in duplication, you can really tell that there is a specific group that is included and divided out into the new entities, emerging entities, and of course, those that have been significantly updated. And I'm not going to go over this because, of course, there is someone else giving that particular topic. Nasopharynx, you can see as well, gone down to only 4 entities for this particular edition. The low-grade nasopharyngeal papillary adenocarcinoma, probably the most important here, with nice examples of both the histology. Here you can see this is actually a Rathke's pouch lesion with pituitary immediately adjacent to it, showing you both the histology and the immunohistochemistry. In the hypopharynx, larynx, and trachea, 10 diagnoses have been included, and this is probably the major focus of squamous cell carcinoma, where you can see each of the squamous cell carcinoma subtypes have been specifically identified. There have been some changes with this edition by adding in some of the additional testing that can now be done, such as PD-L1 and PD-1, in order to be able to suggest how management may be affected by these findings. So that's a new thing for this particular edition. As far as the cartilaginous tumors, a change specifically because it is a separation from those that are included in the bone and soft tissue volume. As you know, the IDH1 or 2 mutations that are seen in central type chondrosarcomas are not identified in laryngeal tumors to any great extent, and this is why they have been separated out, showing classic radiologic findings with the corresponding gross findings, low microscopic feature, and then of course the high power showing you enchondroma-like areas with ischemic change in this area of a low-grade chondrosarcoma. The salivary gland tumor edition, you'll notice, has kept the number of diagnoses the same, although they have been aggregated a little bit. The non-neoplastic lesions have been added. A couple of new malignant category areas have been added as well. But this is, again, something that is going to be covered by another speaker, and so I will go on to a different area. The oral cavity, you can see, has decreased down to 16 diagnoses for this, with actually the new entities being the non-neoplastic ones. So necrotizing salometaplasia, Hex disease, and oral melanoacanthoma has been added, with updates to the potentially malignant disorders, oral epithelial dysplasia, HPV-associated dysplasia, and then updates related to verrucous and carcinoma corniculatum. You will see that for each of the lesions, here's just an example of the oral melanoacanthoma, and the reason why it's included is because it is a very rapid clinical onset with a worrisome feature that allows it to be in the differential for other tumor categories, and so several non-neoplastic lesions have been included. There has also been expansion of the pre-neoplastic or pre-malignant precursor or risk lesions. Here you will notice an example of submucous fibrosis, which is quite common in the Far East, and you will notice the histology that supports these findings as well. The HPV-associated dysplasia, with its karyorectic type appearance of a full thickness dysplasia, has been updated in the oral cavity as well, with the associated findings of P16 or findings with in situ hybridization for HPV high-risk types. The carcinoma corniculatum and verrucous carcinoma has also been expanded, and you can tell here that this is a very nice example, and the illustrations are truly quite spectacular from the book overall. If you think about oropharynx, well, it wasn't included at all in the 2005. Then there were 11 different diagnoses in 2017, and now it's been honed down to really only 3 with hamartomatous polyps, squamous cell carcinoma, either HPV-associated or HPV-independent. As you know, they have been updated as well with the idea of no carcinoma in situ, all of the various subtypes of squamous cell carcinoma recognized, and then classification of the neuroendocrine tumor types specifically separated out, which I'll go over here in just a moment. So, you know, again, here is one of those non-neoplastic lesions that is included just because it can present as a mass-like or tumor-like lesion clinically, and therefore is included for that purpose alone. Here you will notice an area of oropharyngeal squamous cell carcinoma, and in fact, this is the only area of carcinoma that measures about 1.5 millimeters. Here you can see a different area, high power, just showing how the P16 is a very strong supporting finding for the HPV relation of this neoplasm. As you know, with the integration of other organizations, the ICCR, or International Collaboration on Cancer Reporting, has also put out data sets for these areas with accompanying articles in the Archives of Path and Lab Medicine. And with that, you have these very nice reporting guides, as I previously suggested with the one shown for salivary gland. So it allows for a standardization of the reporting so that each person is actually reporting the same thing no matter where they are. And because these are free of charge, you don't have to worry about belonging to a particular society society or national organization. I am including the HPV-associated neuroendocrine carcinoma here from the area of the oropharynx, just to highlight the synaptophysin and P16 reactivity or association with HPV, but this is actually moved separately into the either small or large cell neuroendocrine category that I'll talk about a little bit later on. So we can leave our love for oropharyngeal carcinoma behind and go on now to the odontogenic and maxillofacial lesions. Well, you can tell that this has expanded. There's been a lot of reorganization in this section, with several things moving around, specifically as a reorganization from benign to malignant, whether they are odontogenic primarily, whether they are associated with an inflammatory origin or not, trying to group together various lesions as well with the goal of going from benign to malignant. However, one of the new things that has been added in this location is the TFCP2 rearranged rhabdomyosarcoma. And part of the reason for this is, one, it occurs in young patients and specifically has the greater tendency to be identified within the mandible, maxilla, or skull bones. And therefore, this is a biphasic spindle cell and epithelioid area, either showing sheets or fascicles. Sometimes just one of these patterns will be seen. But one of the most remarkable findings of this is the remarkable immunophenotypic relationship between the pancytokeratins, MyoD1 or desmin, myogenin, as well as ALK. So this means that a panel approach needs to be done in order to at least suggest this diagnosis before actually performing the molecular studies for this. As you will notice, it is fused with either EWSR1 or FUS, so either one of those two can be performed as a FISH break apart in order to detect whether it is being involved. So here is an example of the overlying surface epithelium, a really, really close association. And so you can tell how in this case, the idea of is it a spindle squamous cell carcinoma, and if all you did was a keratin, you'd certainly be deceived. And little area showing a much more rhabdoid phenotype on the left, while a more spindle cell area identified on the right-hand side. But it does have an epithelioid quality overall, even though it is somewhat spindled in its overall architecture. And again, a very strong and diffuse keratin reactivity, as you can tell from the upper right-hand corner, while myogenin or MyoD1 can be expressed in a strong and diffuse fashion, as well as ALK. So those are some of the surrogate markers that can be used in order to suggest doing the molecular finding for this new tumor category. Tumors of the ear, well, they have also changed a little bit with the inclusion now of several of the older lesions. So you can see chondrodermatitis nodularis helicis, cystic chondromalacia osteoma, middle ear papilloma, and even some changes in the squamous cell carcinoma related to DECAF2 fusion tumors. There's also been a renaming of some of these lesions as well. So you will say, are they new or not? Well, you know, they were included in the 3rd edition, but then they were dumped in the 4th edition. And so now they're kind of back, even though they're not really new. So when you say, is anything new? Well, here's a mummy from the 600 BC period. And you will notice when you do an X-ray of that, you're able to see this small area of osteoma. And so, of course, osteoma is still recognized today. Well, the major update here is for the neuroendocrine tumor category, and you can see that this is a neuroendocrine lesion that has gone by so many different names, it probably equals the total number of cases that have been reported over time. But this is partly because it is a very varied growth pattern, showing glandular, trabecular, solid organoid cords, festoons, single cell areas, duct-like structures, and then, of course, this remarkable both epithelial and neuroendocrine markers, whether they are the classic first-generation synaptophysin or chromogranin, or some of the more up-to-date ones, where you have INSM1, ILET1, and SATB2, and then, of course, specific peptides like glucagon, pancreatic polypeptide, etc., while co-expression with CDX2 and GATA3 can also be seen. Now, the labeling in this case is also being utilized, even though the majority fall into low grade, and so would be a net G1, still net G2 and possibly even G3 would be appropriate in these particular cases. So a very diffuse and different architectural patterns all aggregated together in the single low power view. Bone destruction of the stapes can certainly be seen, and therefore this can create some confusion about the biologic behavior. Rhabdoid to plasmacytoid architecture can be seen with these lesions, although quite frequently they will have this very, very delicate inner luminal lining cell, and those particular cells can actually be highlighted with variations in keratin expression or even with CK7, highlighting that population specifically. However, overall, there's a remarkable variability with synaptophysin as well as glucagon, islet-1, SATB2, giving a notion to the idea that this may in fact be of hindgut type origin, and then the somatostatin receptor being something that can be used actually to identify the extent of disease radiographically when using dodecate as the radiopharmaceutical agent to detect them. Soft tissue tumors, well, again, not much in the way of change in number. However, there has been an aggregation of these lesions throughout, with trying to include them specifically all in one chapter, unless the lesion is quite unique and specific. So, for instance, glomerulonephrocytoma does not really involve another anatomic site, and therefore this would be an appropriate location for it. The EBV-associated smooth muscle tumor, phosphateric mesenchymal tumor, extraskeletal myxoid chondrosarc, and GLI1 associated or altered soft tissue tumors are included in this. So as you know, EBV-associated smooth muscle tumor is often in the setting of immunosuppression, vast majority occurring in the larynx in patients who have had a kidney transplant, with these very delicate spindled to kind of epithelioid or blunt-ended cells, showing, of course, by definition, EBV. So here you can tell below the surface spindle cell proliferation, sometimes even a more round cell appearance with vesicular open nucleochromatin and even sprinkling of mitotic figures. And of course, going to show both co-expression with desmin as well as with EBER highlighted in the nuclei. The phosphateric mesenchymal tumors are a neoplasm that has a tumor-inducible osteomalacia, often through the production of fibroblastic growth factor 23, and there should be either clinical evidence of phosphate wasting and or osteomalacia that is reversible when you do removal of the tumor. So one of the things that needs to be seen, of course, is this basophilic or smudgy matrix or floccular calcification. And here you can see an example. So it is a destructive lesion, as you can tell, involving the bone of the jaw. A basophilic background material seen here, more of that grungy granular material adjacent to other areas of osteoid production. And of course, that granularity of the basophilic calcification is quite characteristic for this lesion. Sometimes you'll have fat present within it, as well as a rich vascularity seen in the tumor. Of course, the CISH by messenger RNA for the fibroblastic growth factor can certainly be performed, as you can tell in this illustration. So extraskeletal myxoid chondrosarc, again, one of those tumors associated with the EWSR1, although in this case it is specifically an NR4A3 fusion. Most of them do occur within the head and neck space, specifically around the orbit, intracranial, and sinonasal tract area. So it can often have a very, very characteristic and abundant pale blue myxoid or chondromyxoid matrix material with these clusters and cords, trabecular and cribriform architectural arrays. So often it is a very non-specific finding. And as you can tell here, this myxoid degenerative material creating the cords, and other areas separated out by broad fibrous connective tissue bands. Here is that myxoid material, and you can tell from this low power the idea that this would encompass a number of salivary gland type tumors in the differential diagnosis. Here is an example of the EWSR1 where you can tell that there is a break apart identifying that a fusion partner has been identified, is present, although you don't know which one it may be. The GLI1 altered soft tissue tumors are new in this book, where it's a mesenchymal neoplasm of uncertain histogenesis, although sometimes thought to maybe be of perivascular type distribution. And they are either gene fusions in about 2/3 of the cases, although amplifications are seen in the others, sometimes even those of the adjacent genes being amplified as well. There's often vascular involvement, a wide spectrum of both architectural and cytologic features, arranged in small nests and sheets, and of course quite monotonous in its overall appearance, as you would expect with these gene-associated tumors. Very, very difficult to identify immunophenotypically, so you can tell that it's variable and patchy with a number of different markers. So here is an example of vascular protrusion in this case, another nice area of involvement of the vessels by a tumor that has this sort of nodular or lobular to sheet-like distribution with kind of a myxoid appearance in the background. Areas here showing very, very delicate and fine nuclear chromatin distribution, a little bit heavier in this example that shows almost a paraganglioma-like pattern of growth. And here you can see, again, a myxoid type stroma. Now, remember that I said the immuno is completely all over the board, and therefore you may have areas in a tumor like this where there may be amplification of GLI1, or you may have rearrangement. So either of those two findings can be seen in this newly described neoplasm. The adamantinoma-like Ewing sarcoma category has been included in this book as well. Part of it is because they most usually occur within the head and neck space, involving primarily the salivary glands, thyroid, and sinonasal tract, with this very, very lobular architecture, peripheral palisading, and sometimes showing areas of squamous differentiation. So because it is a co-expression of keratins, P40 and P63, along with CD99 or NKX2.2, is part of the reason why this is such a difficult diagnosis, especially when it occurs in the salivary gland. So here you will notice a high power where you can see that there is a small blue round cell morphology to the tumor. Very prominent nucleoli or chromocenters are seen with a kind of rhabdoid cytoplasmic appearance. Here a little bit different with areas of pycnosis, but still a prominent nucleolus seen in many of the cells. Packeting can be seen in this as well, where there is a stromal deposition of fibrous connective tissue. So if you think about the immunophenotypic profile, I've just put up a small blue round cell differential here and highlighted Ewing and or adamantinoma-like Ewing. And you will notice that there really is quite a lot of overlap between the various patterns that can be seen with a panel approach in diagnosis. So strong P40 is identified here with a strong P63, as well as CK56, which again is going to be quite easily confused with a squamous cell carcinoma category. However, you also have a very strong membranous-like CD99 immunoreactivity, as well as NKX2.2. And as you all know, the NKX2.2 is required for oncogenic transformation and is the downstream target of the EWSR1 FLY1 fusion, and therefore is something that can be sought in these particular cases. Let's now go on to the hematolymphoid area, and you'll notice a slight increase in the number of entities that have been included. Specifically for this area, the new entities include the EBV mucocutaneous ulcer, IgG4-related disease, large B-cell lymphoma with IRF4 rearrangement, juvenile xanthogranuloma, and Erdheim-Chester. So I'm not going to go through all of those. Let me just highlight a couple. This, as you know, with the EBV mucocutaneous ulcer is not actually considered a neoplasm at this time. It's more of a reactive phenomenon in immunocompromised patients. However, those very large polymorphic cells that mimic Reese Hodgkin-like cells in the base of the ulcer can certainly be quite disturbing. And as you can see, the association with EBER with a strong nuclear reaction helps to confirm the diagnosis, while occasionally you will also have CD15 co-expressed. This is the first time that IgG4-related disease has been included in any of the WHO books. And part of the reason for this is, of course, because it does give you a very rich plasma cell infiltrate, storiform fibrosis, and obliterative phlebitis, and usually has some sort of elevation of IgG4, but it is because it presents as a mass-type lesion. And so that mass-type lesion, whether it's in the orbit or the submandibular gland, can really be quite difficult to recognize in this anatomic site. You do need to exclude other known entities, and of course, compatible features with other anatomic sites will be helpful. The book has included a number of different tables, and specifically the criteria for each anatomic site. I'm only including those two here for the head and neck area, but just know that all of the anatomic sites have been included with all of the various nomenclature and what the significant salient clinical and histologic features would be. So when I look at this, I can see that there is a storiform fibrosis. It expands out into the adjacent salivary gland parenchyma. There is a very rich inflammatory infiltrate present. This can, of course, occur also in the sinonasal tract, not just in the salivary gland as illustrated here. Phlebitis, when it is present, is very helpful where there's destruction of the vessel by the inflammatory infiltrate. And of course, the rich plasma cell infiltrate is usually very easy to identify, with an idea of then doing the markers where you will notice IgG and IgG4, nicely illustrating an increased number in the IgG4 and therefore greater than the 40% cutoff ratio. Well, the melanocytic tumors has just slowly decreased over time because now you just have melanoma. And of course, junctional activity in a melanoma involving the mucosal site and then expanding into the submucosal tissues is very helpful in confirming the diagnosis. A spindle cell architecture can be seen with these tumors as well. And just remember that there are a whole number of different antibodies that can be done immunophenotypically, including the most recent of PRAME, but just also remember that there can be incredible immunophenotypic infidelity and anomalous immunoreactivity. One of the highlights as well is the differences in the mutational status or amplification between those that occur in mucosal sites versus those that occur in cutaneous melanomas. And so SOX10 is probably one of the most sensitive and specific markers that can be used here, while PRAME has also been introduced with a very strong and diffuse nuclear reaction, irrespective of the architectural or cytologic feature of the tumor. The head and neck space, of course, includes tumor and tumor-like lesions of the neck and lymph nodes. And specifically in this area, branchioma has been added as well as lymphoepithelial cyst. Well, let me just discuss branchioma for a moment. As you know, this was previously known as ectopic hamartomatous thymoma, and in fact was not included in the previous edition, but has now been included based on its remarkable anatomic site of distribution in the low anterior neck. Haphazard proliferation of spindled and benign cells that have epithelial islands and adipocytes, and of course lacking any primitive elements that would be seen in a tumor that is a teratoma. Plump spindle cells, myoid features are occasionally seen, and even the fat cells are very helpful in this tumor, with carcinoma developing quite rarely. So here you will notice a very well-defined lesion just below the area of the trachea, a nice low power architecturally, showing a mixture of these spindle cells going immediately adjacent to and involving glandular and epithelial elements that also have adipose tissue intimately associated with them, with some areas of even cyst formation. And of course, that spindle cell population giving a somewhat myoid phenotype, which is highlighted here with a smooth muscle actin. So one of the new areas in the neck space with branchioma being included. Specifically around germ cell tumors, teratoma and of course malignant germ cell tumors of an extragonadal location have been included in this book as well, recognizing that it's important to exclude the SMARCB1 deficient carcinomas, and of course also to recognize that these are not metastatic tumors from another anatomic site. Metastases have been aggregated into a single area, although they are still broken down by anatomic site that is affected. And you will notice in these next two tables, the anatomic site with the most common metastatic malignancies, and then what the pertinent immunohistochemical findings would be in order to make a meaningful separation between each of these entities. And it really is a very nice tabular format that you would be able to review in order to understand what are the things that you may be able to do in order to characterize the lesion. And then when you look at the overall appearance, you can tell here is a metastatic adenocarcinoma. Of course, in this case, it turned out to be a prostatic adenocarcinoma highlighted with the NKX 3.1, and a nice example here of a metastatic renal cell carcinoma highlighted nicely with PAX8 in this example. The neuroendocrine neoplasm category is probably the one in which we have had the most update, and this is probably the most significant in the book, with an attempt to harmonize terminology between all anatomic sites. Neuroendocrine tumor, neuroendocrine carcinoma, with neuroendocrine tumor separated out into grade 1, 2, and 3, even though we are not yet fully developed in the overall diagnostic criteria, and neuroendocrine carcinoma of small cell, large cell types, and then finally Merkel cell carcinoma as well. So if you think about the neuroendocrine tumor category, they are both epithelial and neuroendocrine neoplasms arising within the upper airodigestive tract. from the dispersed neuroendocrine system, and therefore functional imaging, like the dotate PET or CT combination, is reliant on the fact that somatostatin receptors are located within the tumor cells, and therefore allow you to be able to document either multifocal disease, as seen on the left-hand side, or an example of metastatic disease, as you can see on the right. So each of those modalities is very, very helpful. Well, when it comes to the neuroendocrine tumor category, we do try to have first that the neuroendocrine features are very well developed, and then separated out into neuroendocrine tumor grade 1, 2, and 3. Grade 1 tumors, no necrosis, less than 2 mitoses per 2 square millimeters. Grade 2 may or may not have necrosis with 2 to 10 mitoses. And then the grade 3 category may have necrosis with a greater than 10 mitoses per 2 square millimeters. So the optimal Ki67 proliferation has not yet been defined for these, even though we are trying to have this be the new standard in order to allow these to be recognized. Remember that there is a co-expression of epithelial and neuroendocrine markers in these tumors, as well as sometimes aberrant expression with other markers, while there is an intact P53 and retinoblastoma. So here you will notice a low-grade tumor, grade 1 in this example, with very nice rosettes. Another example of a grade 1 tumor lacking tumor necrosis or increased mitotic activity. Here is an example of a grade 2 laryngeal tumor. You will see that there is a lower nuclear to cytoplasmic ratio in these cells, a little bit higher here. And while I'm not illustrating a mitotic figure there, I'm showing tumor necrosis present here in this example of a grade 2 tumor. Here you can see 4 or 5 different mitoses in a single high power field, along with areas of tumor necrosis, as you will detect in another higher power from a different area, indicating this is an example of a grade 3 neuroendocrine tumor. So they will co-express keratin. Here you can see a very nice pan-cytokeratin with intact epithelium overlying as a nice internal control, where you can see chromogranin or calcitonin as one of the examples of an aberrant expression. So this can cause problems with thyroid, which is so intimately associated in the area. TTF1 can also be co-expressed in neuroendocrine tumors in this location, but you can see that there is an intact RB as noticed in all of the neoplastic cells here. Small cell carcinoma, obviously this is similar to any other anatomic site, and therefore there is an association with tobacco use, certainly when it occurs in the oral cavity, in the larynx, while in the oral pharynx, association with HPV is also frequently seen. So of course the neuroendocrine features must predominate. This is not just based on immunoreactivity at all. You will see that it is smaller than the diameter of 3 lymphocytes, very high NC ratio, mitotic count of greater than 10 mitoses per 2 square millimeters, with numerous apoptotic bodies and necrosis. And of course, the crush with extravasated DNA or the Azzopardi effect is quite frequently seen as well. So you'll notice a lobular architecture here, crush artifact easily identified, often obscuring the underlying neoplastic proliferation, whereas here you can see the neoplastic cells with that very fine and delicate neuroendocrine salt and pepper chromatin distribution. As I've already mentioned, co-expression of epithelial and neuroendocrine markers were the first or second generation, with aberrant expression with some others. And of course, in this case, global retinoblastoma can also be seen. Now, again, no Ki67 has been identified for the grading, but it is still something where greater than 20% seems to be a reliable cutoff. A very strong keratin, another showing nice synaptophysin, including even little dot-like reactivity patterns, with nuclear INSM1 showing a more sensitive finding for neuroendocrine differentiation. Global loss of retinoblastoma is one of the key histologic features that we rely on as well for the identification of a small cell carcinoma. You will notice a very high Ki67 reactivity in the nuclei of the neoplastic cells here. And I'm just putting in a case from the oropharynx where you can see that in this case, there is actually high-risk HPV by RNA in situ hybridization, highlighting the fact that you can have a tumor driven by HPV, even though it is a neuroendocrine neoplasm. The large cell neuroendocrine, same as other anatomic sites, but remember that IDH2 mutations have been identified, and because SMARCA4 loss is specifically related to the SWE/SNF complex deficient sinonasal carcinoma group, you should not use that particular terminology when that has been identified. So again, much larger than 3 lymphocytes, lots of cytoplasm, speckled chromatin, usually a prominent nucleolus, and again, the same findings immunophenotypically. So here you can see a very large nucleus, tumor necrosis easily identified with lots of mitotic figures, and of course, tumor necrosis and mitoses here, giving you a sense that this looks very similar to what I described as sinonasal undifferentiated carcinoma. Strong diffuse CAM 5.2 and INSM1 in that particular location. Let me just end with paraganglioma for this section, showing that, of course, again, you're going to have those same radiologic findings for this group. And here you can see an example of a CT and an angiogram, as well as an area of specific radionucleotide uptake in order to be able to confirm the diagnosis. Classic findings, in this case, showing some of the area of embolization, since frequently the head and neck lesions are embolized. Expression of tyrosine hydroxylase is very helpful, as is the somatostatin receptor, as you can tell, highlighting the membranes of these cells, and in this example, a loss of SDHB as one of the related findings that needs to be performed in all of these particular neoplasms. Let's end now with the area of genetic tumor syndromes, so specifically those that have sort of head and neck manifestations, by establishing what the associated findings are, recommendations for monitoring and treatment. And so the 15 different syndromes are presented. I'm just going to do the nevoid basal cell carcinoma syndrome as an example. You know, it went back to the 1800s as its original description, but of course was recognized in 1959 and hence given an epidemic phenomenon. It's related specifically to the sonic hedgehog pathway, and you will notice they are both major and minor criteria, with, of course, the multifocal nature of the odontogenic keratocyst, as you can see here, showing a nice separation artifact immediately below the epithelium, and of course, when you have daughter cysts present within it, allowing you to make that particular diagnosis. So I hope that you have enjoyed this whirlwind experience through the 5th edition, and knowing that we are really on our way towards a true extinction of what we deal with when you talk about the NOS category. Thanks so much, and I'll be happy to take any questions.